I'm Howard Rockman, and I'm going to be discussing GPCR, specifically the beta-adrenergic receptor. Now, from a GPCR, the G protein coupled receptor, GPCRs were named for their ability to target and couple to the transducer G protein that was discovered by Al Gilman and Rod Bell 25 years ago, 30 years ago. But essentially, a GPCR is a 7-transmembrane protein that engages a ligand, an agonist, or an antagonist, depending on its pharmacology, to induce a conformational change of the receptor and engage a heterotrimeric G protein. That heterotrimeric G protein of a specific class for that receptor will then activate an effector molecule for the beta-adrenergic receptor, its adenyl cyclase, and will activate a second message, cyclic AMP, for the beta-adrenergic receptor. So when you get up and exercise, norepinephrine is released from nerve terminals, stimulate beta-adrenergic receptors to engage adenyl GS stimulatory protein and activate adenyl cyclase and cyclic AMP, and you get an increase in heart rate and contractility. But work done in the 80s and 90s by my friend and colleague Bob Lefkowitz in his laboratory identified another mechanism that's involved in regulation of the receptor, specifically GRK, G protein coupled receptor kinase, and beta-arrestin. Now, initially discovered, GRKs and beta-arrestins activate the receptor or deactivate the receptor and desensitize the receptor. In other words, they sterically inhibit G protein activation and blunt the response. And it's a major cause of blunted adrenergic stimulation in the failing heart. But their lab and my lab subsequently discovered that beta-arrestin is its transducer itself. In other words, beta-arrestin not only desensitizes, but then activates a signaling cascade or signaling profile that is shared and distinct from G protein. And I'm going to focus then a lot of my talk on berrestin signaling, which in effect is independent or distinct from G protein. This led to the concept of what's called biased agonism or biased signaling. So what's bias? Biased signaling is the concept, ligand bias signaling, is a concept that different ligands stabilize different conformations of the receptor. And now we have data for this based on structural studies. Different conformations of the receptor then engage different transducers. They could engage both G and beta-arrestin. Angiotensin or norepinephrine is a full agonist. In other words, it will engage G protein and beta-arrestin. But there are biased ligands where you have a ligand that stabilizes a receptor and only activates G protein, or a ligand that activates only berrestin signaling. And examples of berrestin activated signals or berrestin ligands is one called carvedilol. And I'll show you some data for that. So beta blockers that activate beta-arrestin signaling are berrestin biased ligands. I want to show you some data, though, that we've done pretty well with pharmacotherapy in heart failure. So data from the consensus trial shown on the left is the one-year mortality of the patients with class 2 to class 4 heart failure that were on Digen Lasix compared to enalapril in the consensus trial in 1987. And the one-year mortality was 60%. For the dapagliflozin, DAPA-HF trial, the one-year mortality on guideline-directed medical therapy, which includes carvedilol, the Entresto, which is sacubitril, valsartan, the ARB, spironolactone, and dapagliflozin, was 5%. Now, the patient populations were actually quite similar between this group and that group 35 years later. So remarkably, we've done quite well. The problem, of course, is that there's huge variability between the clinical trials and real-world experience. And here's one example. In carvedilol, the different clinical trials that showed benefit for the beta blockers, the improvement with one of these beta blockers was anywhere from 30%, 10% to 65%. And a large part of this is the fact that most patients, many patients, have difficulty being on very high doses or the doses that were used in the clinical trials for beta blocker therapy. And I'm sure many have experience with this, that patients will come in and say they're tired on the beta blocker, and they never get to the level that was used in the clinical trial under very supervised conditions. And so there, in our minds, there's a tremendous need for an additional, or at least drugs that could maximize the benefit of a GPCR targeted therapy, but minimize the side effects. And our work, or at least our approach of this, is to target what's called allosteric sites, harvesting or maximizing the receptor at an allosteric point. And so what is an allosteric modulator? So an allosteric modulator is a ligand that binds to a site anywhere that's distinct from the orthosteric site, the main binding pocket of where endogenous ligands bind. Now, the endogenous pocket is actually very conserved across almost all GPCRs in a given class. It's very difficult to find a drug that is truly subtype selective at the orthosteric site. But the allosteric sites are totally distinct and very less conserved. So the possibility of finding a molecule that has that unique binding to a receptor subtype at an allosteric site is much greater. Now, an allosteric modulator can modulate binding affinity and or efficacy of an orthosteric ligand. And I'll show you some data for that. Enhanced subtype selectivity, as I mentioned. And the last point is that allosteric modulators generally don't have intrinsic efficacy. So what does that mean? That means that an allosteric modulator binding to a receptor without an orthosteric ligand binding to it do nothing. So by itself, the drug, in the absence of an endogenous agonist or endogenous ligand, will have very little effect. You could positively activate, enhance the orthosteric ligand. That's called a PAM, positive allosteric modulator, or a negative allosteric modulator, a NAM. So we're embarking now on a DNA-encoded library screen using 1 billion unique compounds. And the way we do this is we've purified the beta-1-adrenergic receptor, put it in a nanodisc, which is a lipid membrane disc surrounded by a HDL belt, so that you have a native environment, a lipid native environment for the receptor, and it's one receptor per nanodisc. And then you have a tag so that we could pull down the receptor. The DNA-encoded library is a unique 1 billion chemical entities, all tagged with a unique DNA code, barcode, which we've done the selection, and currently we're sequencing, and we'll have data in the next couple of weeks on what are the binders to this receptor. I just want to point out that PAMs, NAMs, and what we hope to find, biased PAM, are their goals. And you could imagine that a PAM would be something that would enhance endogenous norepinephrine. That could be used in cardiogenic shock, sinus node dysfunction, chronotropic incompetence. Potentially, what our greatest wish is to find a Berestin biased PAM. That would take norepinephrine and convert norepinephrine into a blocker by blocking G, but enhancing Berestin. And we have some data with the angiotensin receptor that that's a possibility. And so in this screen, then we use a wild-type beta receptor, a beta receptor mutant that we generated using sortase, which is a enzyme that we could physically attach a phosphorylated tail. There's some nuances there, in complex with G protein or beta-arrestin, and our relative controls. As a proof of concept, though, we went back to a screen that Bob Lefkowitz did a couple years ago, a DNA-encoded library screen for the beta-2 adrenergic receptor. And here, he used the beta-2 receptor in a DEL screen with a couple million chemical entities. And what he found was this compound 6. And compound 6, this is a competition binding curve looking at a beta-2 or a beta-1 high affinity ligand that's hot, that's I-125 labeled, and we're looking at the increase of affinity in an isopaterenal competition curve in the presence of compound 6. So a leftward shift indicates that compound 6 is stabilizing the receptor in a high affinity state such that lower doses of isopaterenol could wash off the hot ligand. And so this is essentially a PAM, a positive allosteric modulator for the beta-2 adrenergic receptor. Well, we tested this for the beta-1 adrenergic receptor, and what you could see is that there was actually very little shift for the agonist. But what was remarkable was a leftward shift for carvedilol. So this compound 6 binds to an allosteric site on the beta-1 receptor and activates or stabilizes a conformation that carvedilol notices and in fact enhances its affinity for carvedilol. It's unique for carvedilol. So of the beta blockers that we tested, shown here, none of them were affected by compound 6 except carvedilol, and these are the competition curves for that. It also, not only does it enhance affinity, it enhances second messenger and efficacy. And so we've done a couple of assays to test whether this compound 6 enhances receptor downstream effects. So from a G protein perspective, does it increase cycle KMP? Well, so we use an assay called a glow sensor assay, which is essentially an assay that measures the amount of cycle KMP in a fluorescence, not a fluorescence, in a luciferase assay. And so isopaterenol increases cycle KMP as you would expect. Compound 6 had no effect. Carvedilol is a beta blocker. So it doesn't increase cycle KMP, and compound 6 didn't enhance that. So that's all good. It's a beta blocker. But what it does is enhance beta-arrestin signaling. It takes carvedilol, which is already a biased ligand, and this is an assay for berestin signaling, and there's an 8.5-fold shift, enhanced activation of berestin. It also increases ERK. So carvedilol is a berestin activator, will activate berestin signaling, and one of the pathways that berestin will activate is ERK signaling, and we've worked on that for many years, and I won't go into larger the details of that, but we've defined the pathway of how that works. And you could see that carvedilol activates ERK, and in fact, compound 6 in combination enhances that ERK signal. And it's unique for carvedilol. It doesn't do it for any of the other beta blockers. Well, so how would this work then? One could imagine that if it's a beta blocker and enhances a beta blocker, what the potential would be is that you administer a low dose of carvedilol so that an individual would not have as much side effects to the beta blocker, but enhance the berestin stimulation and enhance the cardioprotective effect. So we tested this in vivo, and so this is then hemodynamics in a mouse that's instrumented in a dose response to isopaterenol for both heart rate and contractility as assessed by dPDT max. And so the black line is no treatment, just isopaterenol, and you can see there's an increase in contractility and an increase in heart rate. The red line is maximal doses of carvedilol, and what one sees is you blunt the heart rate response and the contractility response. This would be analogous to a person that's on carvedilol and tries to exercise and gets winded because they blunt their heart rate response. But if you treat with low dose of carvedilol and compound 6, you do not blunt the heart rate response with low dose. So the question is that cardioprotective? And so what we did is an ischemia reperfusion assay, and here you have a tunnel positive staining or apoptotic rate in vehicle, compound 6 alone, low dose carvedilol, or low dose carvedilol plus compound 6. And as you could see, there's about 10% tunnel positive staining and ischemia reperfusion in the controls. Carvedilol diminishes the apoptotic response, but compound 6 dramatically decreases the apoptotic response. So what we have here then is what's called a biased allosteric modulator. In the presence of this allosteric modulator, it stabilizes a conformation that now the orthosteric ligand, in this case carvedilol, enhances Berestin signaling and blocks G protein signaling. And that's compound 6 for the beta-1 adrenergic receptor. Of course, our dream is to identify an allosteric modulator that takes norepinephrine and does the same thing, and hopefully that will be, we'll see that with our current screen. So let me stop there and take any questions. I thank the people in the laboratory, particularly Lan Mao, who does all our surgery now and has been with me for many years, Alyssa Grogan in the lab, who's doing the screen, and the other members of the laboratory. Thank you.